of these scientific events. The first speaker is an eminent and recognized and internationally appreciated person, Professor Schweitzer, in the field of musculoskeletal imaging. And I think this is the first time he with us. We're very glad to have him so many times. He's very helpful to accept some of our colleagues whom they trained upon his hands. So we do appreciate your help and do thank you very much. He's going to give us a lecture about a very important topic, which is pathophysiology of tendon disorder. Please.
Thank you very much. Sometimes when I talk to trainees, I start out saying, I have no interest in radiology. Radiology has no interest in this. Well, what's interesting to me is understanding diseases. And radiology is the best way to understand diseases because you can see what's happening in real time to diseases. So we're going to speak about tendons and mostly not radiology. Some radiology, but mostly not radiology. Because if you understand something, the radiology is easy. So what are tendons? They're part of the musculotendinous unit, and their function is to transfer energy from one bone to another. So I have two bones, I have a muscle in between, that muscle has a tendon, that tendon causes the second bone to move. That's what a tendon does. Every muscle has a proximal tendon and a distal tendon. The proximal tendon is very small, vestigial, so we don't tend to be concerned about it, but they do have a proximal tendon. It's important to understand that a normal tendon is extremely strong. You can lift about 10 cars with the Achilles tendon. 10 cars without a tear. So if they do tear, they must be degenerate. No normal tendon ever tears. There's a famous paper from Czechoslovakia where they looked at approximately 10,000 tendon specimens in their archives, resections for various reasons. And not a single one out of 10,000 was normal histologically. But in children, they are normal. So children don't tear tendons. So children get emotion fractures. I think one of the speakers mentioned that yesterday. And that's because their tendons are normal, and normal tendons are extremely strong. They have a little bit of stretch to them, a little bit of elasticity. That elasticity protects them, but it decreases their effectiveness, right? So if I'm pulling something, it's much more energy efficient to pull it with a rope than a rubber band, right? The rubber band stretches and some of that energy is lost to the stretch. So when God designed your tendons, he or she designed it so there would be a little bit of stretch, but not too much. Now it's very important to understand how tendons are organized. I'm going to speak about ligaments shortly. Tendons and ligaments, and to a lesser degree, cartilage, are very similar structures. They are similar in 4 ways. Way 1 is that they're predominantly 90% collagen, predominantly collagen. The second way is they also have ground substance in them, termed proto-aminoglycans. The third way is they have sparse cells. They have very few cells. And those limited number of cells limit their healing potential. So ligaments, tendons, and cartilage have those similarities. And the last similarity they have is they're predominantly avascular. Ligaments a little bit less so. But that also limits the healing potential. So keep that in mind. Another way tendons and ligaments are related is they have this hierarchical organization. And what hierarchical organization means is it just keeps on repeating itself, like a clone. And we'll show you this in a lot of detail. So the cells and tendons are called tenocytes. They're a variant of fibroblasts. Tendons are 2/3 water. Anyone know how much water is in muscle? Big guess. Also about 2/3. And it's interesting that on MR, when you do a fluid weighted image, a tendon is black, but a muscle is gray. And that's because of the ground substance. That's because the water in tendons is bound, and the water in muscles is free. Now, tendons are mostly type 1 collagen. We spoke yesterday about ACL repairs. Mohammed, I think you did read, and he said it undergoes ligamentization. Well, ligamentization means the collagen changes. So it changes from type 1 to type 3 and type 2, which makes it weaker. We'll talk about that. And it's 5% elastic. If you look at undergarments have spandex in them. Yes? Not serious, I'm not joking, right? And that spandex gives it a stretch. The elastin is like spandex. It's the exact same thing. Undergarments are about 5% spandex, right? Tendons are 5% elastin. They have that same amount of stretch. And they have the proteoaminoglycans. So we'll speak about that shortly. So here's an old-fashioned T2 weighted image. And I'm pointing out something I mentioned a few seconds ago. The tendon is black and the muscle is gray. They have almost the exact same amount of water. And the difference is tendons have bound water. The water is bound by glycosaminoglycans. And that's what makes it different. So tenocytes, you don't get much snow. I imagine you get no snow. But there's an expression that no two snowflakes are the same. Have you ever heard that expression? Probably not. But yes, sir.
Yeah, it's not knowing yet.
And no two tenocytes are the same. Every tenocyte is unique. And that protects you. So there'll be one tenocyte for a 5 Newton force, another tenocyte for a 6 Newton force, another tenocyte for a 7 Newton force, another tenocyte for a 7 Newton force going in a different direction, and a 7 Newton force going in yet a different direction. So each tenocyte has like one specific jump, an energy vector in a specific direction. And that protects the tendon from tearing, because you're only going to kill one tenocyte at a time if you overdo it. And you still have 999,000 tenocytes to do their job. That's very different than hepatocytes or renal cells. Very unique to this. They only make up about 3% of tendons. We talked about that sparsity, so you don't want to kill too many of them because you don't have any reserves. And their function is to regenerate the tendon. They secrete proteoaminoglycans, I keep on saying that long word, and collagen. Now let's talk about collagen for a second. I told you, this talk is not about radiology. Collagen is the origin of life. And most biologists believe that. So if I grind up collagen, I grind it up, I put it in a dish, I put water in, it starts to form strands. If I grind up any other substance in your body, calcium, hydroxyapatite, anything, they don't organize, they just stay ground up. Collagen self-organizes. It's an amazing thing. There's no neural system, there's no cells, it just starts forming strands. And then those strands coalesce into a tissue, that tissue coalesces to an organ, that organ coalesces into a species, and then you have life. So a lot of biologists will say that collagen is the origin of life. If collagen wasn't self-generating, self-organizing, there would be no life. So here's a histologic specimen. The pink is the collagen. Can you see the collagen in pink? And these are the tenocytes. The purple are the tenocytes. You see how elongated they are along the long axis of the tendon? Do you see how this one looks different than this one, looks different than this one, how they all look different? And that protects tendons from having acute injury. That's why acute injuries are very rare in tendon disorders. So here's an MR. I think this was a 14 Tesla MR. And we can see the organization of the collagen. It doesn't really look like that. It looks like this. Can anyone tell me, other than the color, the difference between this and the MRI? This is wavy. Can you see that? And this is not wavy. So we said elastic provides some elasticity. The waviness also provides elasticity. So when we talk about hierarchical organization, at every level it repeats itself. So at the chemical level it's elastic. At the physical level it's this undulation of the collagen. And that's what we mean by hierarchical organization. So you get pro-collagen, and pro-collagen will self-organize into collagen. Oh, sorry. Into collagen fibers. Again, it does that on its own. It's the only tissue that does that on its own. And then surrounding those fibers is an endotenon. Tendons are avascular, the blood supply and neural innervation comes from the endo, the epi, and the paratenon. So around the fiber is the endotenon, then we get subfascicles and fascicles, and around that is the epitenon, and then we get bundles and a tendon, and around that is a paratenon. And this is the hierarchical organization. It's constantly repeating itself. So we're going to build a tendon. So I grind up some collagen, and it forms a fiber on its own, a fiber on its own, and a bunch of fibrils on its own. Now tendons transfer a vector in one direction, right? But sometimes your arm goes a little bit to the side, right? It's not a perfect curve. And then you have things called cross bars, cross connections between the tendon fibers, the collagen fibers. And the more off axis the vectors are, the bigger those cross links are. So in my biceps, which really is very longitudinal, I have very limited cross links. In my pectoralis, which is like this, I have a lot of cross links, because the vector is in a bunch of different directions. And a lot of tendons are in between, like the supraspinatus. Okay, so now I have a fascicle, and around that is a endotenon. And it's reddish because that's where the blood supply comes from. And then I'm going to get another fascicle, and I cross-link that. And I have another endotenon around that. Hierarchical organization. I have no idea how long this took to do. And the same thing again. And another endotenon. And now I have a fascicle, and now I cross-link each subfascicle to the other subfascicle. Again, it keeps on repeating itself. You have cross-links at one level, you have cross-links at the next level, and then around that is the epitenon. So endotenon, epitenon, and again the same thing. Endotenon, cross-links, endotenon, cross-links, endotenon, cross-links between the fascicles, and now I have another epitenon, and now I cross-link one epitenon to another epitenon, and then around that is the paratenon. Now, all tendons have a paratenon. Some tendons have a synovial sheath. And the tendons that have synovial sheaths are tendons that change their axis of motion. So the biceps begins horizontal and turns vertical, right? It has a tendon sheath, proximally. The distal biceps is purely vertical, no tendon sheath. Achilles, straight up and down, no tendon sheath. Peroneal tendons curve, tendon sheath. So every tendon has a paratenon. Tendons that change their axis of motion have a tendon sheath as well. So do you understand the concept of hierarchical organization? Good. So I'm going to go through this slide again. And here we can see that again, this is a 5T image, and this is the endotenon, this is the epitenon, this is the paratenon, and you can see the fascicles and subfascicles. And that's what forms that internal signal when you're looking at a tendon. And you can even see it on regular imaging. When you're looking at the Achilles tendon, that internal signal is epi and endotenon. That's what you're seeing. So the tendon strength is related to its elasticity. And its elasticity is related to three things. Elastin, like the spandex, the chemical, the undulation of the fibers, and then on a submicroscopic level, a thing called the crimp. And the crimp is that collagen fibers, although they look like a tube, are really like an accordion. So if you do electron microscopy, it looks like an accordion, and that's called a crimp. So that stretchiness gives it, protects it from injury. It should say strength, it should say protection. The other protection is the tenocytes, right? Every tenocyte is different. So when a vector comes in one direction with one energy, it will kill one tenocyte, and the other 999,000 will survive. Now the last part of the strength of a tendon has to do with a twist. So how do you know, Egypt is famous for cotton, right? How do you make cotton thread? No trick, no trick. How do you make cotton thread? So you get the cotton fibers, right? And you spin them. And when you spin them, it makes a thread, right? So we have collagen fibers, and to make it stronger, we spin them at the end. And that's where you'll see the internal signal, because that spinning at the end gives the end of the tendon, where most of the vector is, strength. And I'm going to show you examples. Okay, again, although it looks longitudinal on ultrasound, you see the undulation. Now, remember, we had a higher power view that showed you that each of these tenocytes are different. This low power view shows you that they're oriented in columns, right? One after the other, after the other. Can you see that? Do you ever see pictures of, I know you wouldn't, of the American Revolution? So in the American Revolution, the British soldiers, they would have one guy on the ground shooting, another guy behind him getting ready to shoot, and a third guy behind him loading, right? Did you ever see those pictures? So if the first guy gets killed, the second guy goes in, and the third guy goes in. It's kind of what the Russians are doing in Ukraine. And that's why you have all these tenocytes in a column. So again, if the vector comes in here, it will kill this one, but the other ones in a row will be protected. Okay, and that's another way the tendon is immune to acute injury. Now this tendon looks less organized than the other ones I showed you, right? So this is pectoralis, and this is because the vectors are coming in at all different directions, and what you're seeing is the collagen fibers are now in different directions, and we'll have more crosslinks. The more different directions of vectors, the more crosslinks. Now tendon lubrication. So tendons, again, to be protected from injury, have to have motor oil around them, right? So your car cylinder has motor oil around the pistons, so the pistons don't have friction with the, I don't know what the rest of the engine is called. What's the rest of the engine called?
Look.
Something. Okay. So the motor oil provides, limits the friction, and synovial fluid limits the friction. As we said before, tendons that change their axis of motion has synovial fluid and synovium. Synovium has 2 cell layers, and tendons that have big synovial sheaths have a thing called a vinculae in the sheath. And I've been in this business for a long time. Until about 3 years ago, I had never heard of vinculae. So here's a biceps tendon, T2 weighted M. Here's the tendon, here's the synovial sheath. You see these black spikes coming out from it? Can you see those? If you look at every M on the shoulder, you will see it. And those are called vinculae, and the big one is the greater vinculae, and this little one is the lesser vinculae, right? Not a trick question. And you have a bicycle wheel, right? You have a hub and a tire. So the hub is your tendon, the tire is your synovial sheath. And your bicycle hub has spokes that come out that connect it to the rim, right? And the reason why you have those spokes is to keep that hub centrally in your wheel so you can spin the wheel and the hub doesn't move. The vinculae are like spokes. They keep that tendon centered. So when the vector comes through here, we don't waste energy with the tendon going up and down, side to side. It goes straight up and down. Those are vinculae. And again, tendons that don't change their axis of motion, like the quadriceps tendon, have a paratine on it, not a synovial sheath. This is a synovial sheath. This is a paratine. I think I covered all that. Okay. And so here's an example. This is the synovial sheath. This is the synovium. And you see it's 2 cell layers that. And what's around the synovium? Any budding pathologists here? Any medical students? Fat. So these are lobules of fat. And there's a thing called essential fat. Something I like to think of when I'm having dessert. Do you know what essential fat is? Essential fat is when you starve, it's the last fat that you lose before you die. And one example of that is myelin. Myelin is fat. You don't want to metabolize myelin, or you're not going to have a brain, you're not going to have a nervous system. So when you starve, it's the very, very last thing to give up, and that's called essential fat. The periarticular fat is essential fat. Half this fat pad is essential fat. When you gain and lose weight, half this fat pad doesn't get bigger, it doesn't get smaller. And this is to cushion the tendon because it cushions the synovium. So we have lubrication and we have cushion. So here's your vinculae, so here's your tendon, and the vinculae attach the tendon to the tendon. Now, some tendons have bursa. Now, there are a lot of reasons why you have a bursa, and I won't go through them, but for tendons, the reason is when it's close to a bone, the bursae provides a cushion. The fat provides a cushion, and the bursae provide a cushion. So here's your tendon, here's your bone. I have a bursae between the tendon and the bone to provide a cushion. And a good example of that is your shoulder, the subacromial bursae will stop it from getting wear and tear as you move your shoulder on your acromion. Now, just like tendons can get synovitis, bursae can get bursitis. And 2 things happen in synovitis and bursitis. One thing is it can get bigger, it can get distended. And the second thing is it can change its internal composition. Typically gets more protein and more cell, as demonstrated by changing that to blue. So when you get bursitis, it could be a big bursa or a bursa that just has differences in its fluid. And these are just examples of bursa. We spoke about this yesterday with the elbow. This is the bicipital radialis bursa, which provides a cushion so when you pronate and supinate, the radius and ulna don't crush your biceps. And this is your prepatellar bursa, which cushions your patella ligament or tendon, depending on which school of thought you have, adjacent to the ground. Now, tendons can also be in fibro-osseous canals. There are three types of fibro-osseous canal. One has a nerve only, one has a tendon only, and one has a nerve and a tendon. Sorry. One has a nerve only, one has a tendon only, one has a nerve and a tendon. Can somebody give me an example of one that has a nerve only? Or most people say neuroforamen, so you're better than most people. And how about a tendon only? Bicipital groove. And tendon and nerve, carpal tunnel. Now, the fibro-osseous canal, the osseous is the floor, the fibro is the roof. And we call the roof a retinaculum. It's just collagen organized like a roof. I was very into animation when I did this talk. So here you have a bone, and here you have a tendon. And the tendon would normally sublux, right? Yes? So these are fibro-osseous canals, and these yellow and red are retinacula that stop the tendon from bowstringing. We say that in English. What's the Arabic word for bowstringing?
Close.
Close. To stop it from bowstringing, we have these retinacula. Now, sesamoids are different than accessory ossicles. I spoke a little bit about accessory ossicles yesterday in the osteogonum. A sesamoid is a lever. It changes the axis of the tendon. So your os peroneum, your peroneus brevis comes in lateral and inserts lateral. Your peroneus longus comes in lateral and inserts medial. So you have an os peroneum, a sesamoid, that acts like a lever to change the axis. Your patella is the biggest sesamoid in your body. And that changes the axis that allows your knee to flex. So sesamoids change the axis of motion of the tendon. So here's a fibro-osseous canal. So here's the floor, which is always bone. And you can have a nerve, you can have a tendon, or if it's big, you can have a tendon and a nerve. And then on top of this is the retinacula, and that forms a roof. And the retinacula stops it from bowstring, right? Now sometimes the canal, the floor, the osseous part, is too shallow. Too shallow. And when it's too shallow, you can get subluxation of a nerve or a tendon. That's the major reason why all the nerves get abnormal in the elbow, is subluxation. And when that happens, again, God forms an osteophyte at the edge of it. And that osteophyte acts to make this deeper. Can you see that? But this osteophyte is sharper than the normal canal is. And it will start tearing the retinaculum. And then you'll get a torn retinaculum. And when the retinacula tears, the tendon is then dislocated. So that's the natural history of tendon dislocation. The theory is you're born or you develop a insufficiently deep osseous part of the canal or a hypoplastic retinaculum. Okay, so that's what happens when you get carpal tunnel syndrome, as demonstrated here. This is my first MRI images, I think, in this one. Not really. And here is a pulmonary lesion with bowstring, because the retinaculum on the work. And a biceps subluxation, and you can see the spur. Can you see the spur at the edge of the bicipital groove? When you have bicep subluxation, look for that. You'll see it in a little bit. Okay, the next part of the tendon anatomy we're going to speak about is the enthesis. And so a tendon begins at the myotendinous junction, right? And you can think of that as muscle gradually becoming a tendon. And the enthesis is a tendon gradually becoming a bone. And it has to be gradual, because anything that's abrupt gets injured, right? If you're going to injure your small intestine, where's the most common area of blunt trauma to the small intestine? Around the ligament of Treitz. Because there's an abrupt transition from thick small bowel to relatively loose small bowel. When you get a brain shear injury, where do you get a brain shear injury? Gray-white matter junction, right? Because the white matter is rigid, it's fixed, the gray matter is loose, and that demarcation is an area where you get injured. So to prevent an abrupt transition, all these transitions are slow and gradual to protect you from injury. The whole design is to protect you from injury. So in the enthesis, we change from tenocytes to fibrocytes to cartilaginocytes to osteoclasts. Gradually transition. The fibers change from longitudinal to off-axis to very off-axis to vertical. And the fiber orientation changes. So it's a gradual transition, and we can see that transition histologically in imaging, and I'll show you. And we generally classify entheses into fibrous or fibrocartilaginous. But because the enthesis is gradual, you don't injure at the enthesis. You injure adjacent to the enthesis, traumatically. So here's a fibrous enthesis with fibrous periosteum and muscle, and this would be the deltoid. And here's a cartilaginous enthesis where we see the tendon fibers eventually come into bone. You see the vacuoles in bone? And that's the concept of an enthesis. Now you can injure entheses. This was a professional hockey, ice hockey player. And you can see the edema in the enthesis. But it's rare. It's rare. I've seen it. Now the other transition, so the transition in one is at the end of the tendon, the other is at the beginning of the tendon. The muscular tendinous. And again, the muscles slowly get smaller, the tendon slowly gets bigger. A tendon doesn't suddenly start, it gradually starts. And this is a point of failure. So why is the myotendinous junction a point of failure and the enthesis not a point of failure? Anyone? Because bone is pretty strong and muscle is not as strong. So the enthesis is really strong. It's pretty hard to fracture bone. But if I have a vector comes in, I'll get a muscle contusion much faster than I'll get a bone fracture. And this is an example just of a triceps injury and a biceps injury. Now we've talked a little bit about tendon blood supply. In sheath tendons, it comes from the synovial sheath. In all tendons, it comes from the epi, endo, and peritoneum. Now you also get blood supply that comes down from the muscle, and then a little bit of blood supply that comes up from the entheses. As you get older, the blood supply to your brain gets worse. Hopefully, a few years left for me. The blood supply to your heart gets worse, and the blood supply to tendons gets worse. And that's why older people get rotator cuff tears, and younger patients do not. So here's a tendon, and we have blood supply coming proximally from the muscle, distally from the enthesis. Note the enthesis is smaller than the muscle. And then we have a synovial sheath, and we get blood supply from that synovial sheath. And you'll notice an area of the tendon that has relatively limited blood supply. Circle. And that's called the hypovascular zone or the critical zone, because it's critical at risk for ischemia. And that's where tendons tear. And they tear there because that's the area that has the most limited blood supply. So this, I like this case. This was a case done for osteomyelitis. But at the edge of the film, you can see the vessel from the myotendinous junction coming in. Can you see that? It's a contrast damage. And you can see the little vessel coming in from the adhesive. And you can see the blood supply coming through the peritoneum. Kind of similar to what I showed you. Okay, so that's all anatomy. So 2/3 of the talk. And now we'll do pathology. So what happens pathologically? Well, it's never an acute injury, or almost never an acute injury. You get a micro tear, and then you get some healing. And that healing is limited because the blood supply is limited and you don't have many kemocytes. But you get some healing. Then you get another micro tear and healing. Another micro tear and healing. And again, each of these healings are insufficient. And that leads to tendinopathy. So tendinopathy is an inadequate healing response to injury. You have to define it. Or some say tendon degeneration. And that tendon degeneration leads to synovitis. Now they used to, and they still do this, but not as often. When you have a tendon disorder, cast it. So if my peroneal tendons were inflamed, I would go see an orthopedic surgeon and they would have put a cast on. Have any of you had a friend or a colleague who had that done? Okay. And the reason you do that is to cause the synovitis to die down. Because the synovitis is both good, but mostly bad. We talked about this with sinus Tarsi syndrome. You get metalloproteinases. You get bad stuff that get released when you have synovitis, and they cause the collagen to break down. So if you cast someone, the synovitis dies down, you disrupt that cascade, and maybe they'll go back to this healing microtear. So now you get synovitis. That synovitis worsens the tendon degeneration. And then, eventually, you'll tear. And when I say tear, I say macro tear. Because there have been hundreds, if not thousands, of micro tears before you get a macro. Now let's just talk about how to evaluate tendon by imaging. Now we'll get to some imaging. Men have bigger tendons than women. They have bigger muscles, they have bigger tendons. Older people have bigger tendons than younger people. Degeneration. Taller people have longer tendons than shorter people. Right? They have a longer distance to travel from the muscle to the bone. Heavier people have bigger tendons than light people. They have more mass to lift. If I'm lifting my arm, my forearm may be heavier. So this is just an example of a variation of tendons. Not quite a patella alta, but a patella vata. Now in tendon injuries, we often distinguish between acute versus chronic versus overuse. And one of the themes of this lecture is that it's all chronic, it's all overuse. The only difference is if you perceive an acute event or you don't perceive an acute event. I had a friend of mine who was an orthopedic surgeon who tore his rotator cuff at a baseball game. Wasn't playing, was watching. And he said, I know my cuff didn't tear at the baseball game, but I swear I believe it tore at the baseball game. He knew intellectually that it had a micro tear, a micro tear, a micro tear, and a micro tear. And he just happened to be at the baseball game when all those micro tears accumulated. He could have been eating dinner. He could have been sleeping. He could have been doing, it just happened to be that point in time that was destined for it to happen. But he believes, intellectually, that it happened from the baseball game. Emotionally, but intellectually he knows it didn't. So we make this distinction, but it's kind of artificial. So what do we see on imaging? Well, the first thing we see is thickening or alterations in tendon shape. So here's an alteration in tendon shape, right? The normal anterior aspect of the Achilles tendon, after the soleus comes in, should be straight. And this is bowing out. And you can see it's too big on cross section. So this is a very abnormal tendon. This is a tendon that may go to surgery. And it is a torn tendon with a microscopic result. Here's a patient with severe rotator cuff tendinopathy and a big, thick tendon. We'll talk about signal in a second. Jumper's knee, big, thick tendon, some signal, but mostly abnormal size and shape. Now, another thing you can get in tendons is not internal signal, but loss of the magic angle. So the magic angle is something that you'll see on images with short teeth, usually in the 20s. And so here's the posterior tibial tendon, magic angle goes away with a longer T. Now to get magic angle, you have to have two things. One is a short TE, and the second is a highly organized tissue. And we showed you how highly organized the tendon is, right? When you get tendinopathy, it gets disorganized. So you can't get magic angle phenomena because one of the predicates for it is missing in the organization. So you'll see loss of magic angle. The next thing you can see is susceptibility artifact. So here's a big calcified deposit in the Achilles tendon, and that's a specific type of tendinopathy that you know, but we will get to in a minute. And then excessive fluid, and here's perineal synovitis. And again, normal fluid is basically a milliliter. Little bit of fluid. Anything more than barely perceptible is probably abnormal. And when you get synovitis, you get these hypertrophy nodules of synovium. And when you do high-powered microscopy, you can see the vascularity in them and how many cell layers they have. Remember, the normal synovium is only 2 cell layers. So synovitis is a response and a cause of tendon disorder. So it will lead to wear, to abnormal collagen, which leads to more synovitis, which leads to a tear, which leads to more synovitis. So synovitis is not a good thing. Don't know why it's there, but not a good thing. So here's the anterior tibial tendon, post-contrast image, synovitis around. So there are 4 types of histologic abnormalities in degenerated tendons. And you should be able to describe each of them on images because they have characteristic appearances and they have characteristic prognoses. The most common is termed hypoxic. And we said, Mohammed pointed out, it's hypovascular, so it's prone to hypoxic degeneration. Now, hypoxic degeneration gives you an enlarged tendon without internal tendon. And we can see the reactive mayoedema here, but that is any less abnormal than a tendon with abnormal signal. In fact, it probably is more abnormal than a tendon with normal signal. Some people call that fibrinoid degeneration, but most people call it hypoxic degeneration. And you see that in a black enlarged tendon. The second most common degeneration is mucoid. And mucoid is vacuoles within a tendon. Hypoxic is symptomatic. So that patient here may present with medial pain. Mucoid is usually asymptomatic. And when someone believes they had a spontaneous tendon tear, it was only spontaneous because the symptoms were occult. And that's likely mucoid degeneration. So here's the distal PTT. Can you see the internal signal? Mucoid degeneration, usually longitudinal. Usually longitudinal. And then can you see the mucoid vacuoles on histology? You see the tendon, the pink is the collagen fibers separated by the white, which is mucoid vacule. And then on ultrasound, you often will see the mucoid vacuoles, and they'll be hypovascular because they cause an inflammatory. and another mucoid degeneration of the posterior tibialis tendon. Achilles tendon. Okay. Now calcific degeneration and tendinolipomatosis. Calcific tendinitis occurs in specific tendons. Right now, every tendon gets calcific tendinitis. It's most common in the supraspinatus in the shoulder. You can get it in the Achilles tendon. You can get it in the gluteal tendon. But in general, you'll never get it, rarely get it in the bicep tendon or the tricep tendon. Specific tendons. Now, calcific, it's thought that you go down one of these degenerative pathways. So if you go down the hypoxic pathway, you'll get a transverse tendon. If you go down the mucoid pathway, you'll get a longitudinal tendon. If you go down the calcific pathway, you won't get a tendon. Less common. And if you go down the tendinolipomatosis pathway, nothing will happen. And we'll show you that in a second. So here's calcification of the supraspinatus, not very hard to see. And on histology, we see the big crystal of the calcific deposits. Now, tendinolipomatosis, I hid the image, I'm sorry about it. It's seen in the quadriceps tendon. So when you see excessive signal in the quadriceps tendon, look to see if the patient had coronary artery disease. Probably did. And that's tendinolipomatosis. It's fatty, just like you get cholesterol deposits in your vessels, you get cholesterol deposits in your tendon. But it's not important. It doesn't lead to symptoms, doesn't lead to damage. Kind of an incidental finding. Hypoxic is about half of tendon disorders. Mucoid is about a fifth of tendon disorders. Tendinolipomatosis is a fifth of tendon disorders. And calcific is the rarest. It's about 5% of tendon disorders. Now, marrow associations. We showed you an example of this already today as well as yesterday. This was the case we showed you. You get reactive changes underneath certain tendons, and that finding is often a manifestation of pain. So can you see pain, doctor? This is one way that you can see pain with a tendon disorder. Now, certain osseous abnormalities put you at risk for tendon disorders. We talked about a shallow groove. Reem, I think, spoke about yesterday Haglund's syndrome. So here is Haglund's syndrome, where you have an enlarged calcaneal tuberosity, retrocalcaneal bursitis, an abnormal distal Achilles tendon, and reactive marrow edema, because that Haglund's keeps on getting bigger and bigger because of the stress of foot walk. And we talked about grooves leading to subluxation. You see how this perineal groove is not only not concave, it's convex. And another groove, and you see how it forms the osteophyte at the edge to kind of stabilize. And then accessory navicular. Here is a corner with navicular. Here is an accessory navicular. 4% of the population has one or those. 40% of people with PTT tears have one of those. So we're going to end with the pathophysiology and how it varies by tendon with some examples. So most people, as I said before, it's overuse or perhaps just use, not overuse. Most people who have rotator cuff tears are not professional athletes. They're just normal people who use their shoulders. So that's Achilles tendon tears, patella tendon tears. So here are two Achilles tendon tears, use or overuse. Patella tendon tear, jumper's knee, women basketball player. We see thickening, reactive marrow edema, internal signal, overuse, most common cause of tendon disorder. Then we have critical zone. We spoke about this several times. Ischemia, much worse in older people regardless of activity, and related with systemic cardiovascular issues. I did a study once, I thought it was good study, where we looked at aortic arch calcification and related it to rotator cuff. Because you ever hear the Framingham heart study? Very famous 50-year heart study from Harvard where they followed patients for 50 years. And buried in one of those reports were people who had aortic disease, had more shoulder. Just like buried in one of the papers. Awesome, I thought. We could study that, you know. We get chest x-rays on a lot of people, we get MRIs on a lot of people. Let's compare the calcification in the aorta, age stratified, to how much they have rotator cuff tears. And sure enough, those who had aortic calcification had more rotator cuff tears. We kind of know it's ischemia. It kind of makes sense. So here's a rotator cuff tear, ischemic. Posterior tibial tendon tear, we spoke about this yesterday. Orthopedic surgeons call the posterior tibial tendon the coronary artery of the ankle. Kind of same result. Then you have impingement. Biceps, proximal, rotator cuff tears, posterior tibial tendon. So here's a PTT tear in the sagittal. Here's a biceps tear. And subluxation, perineal tendon, extensor carpio-ulnaris, proximal biceps. So ECU subluxation, PTT dislocation. Now, I spoke about these as being independent phenomena, but I'm sure, even though it's early in the morning, that some of you noticed that the rotator cuff is listed more than once, and the Achilles is listed more than once. That's because although intellectually we separate out these processes, in any individual patient, more than one is probably happening. So, perineal tendons, biceps tendon, there is subluxation, there is ischemia, and there are impingements, and they all work together to get tendinopathy. So it's an intellectual construct, and to some degree a false intellectual construct, to put them all together or to separate them, because they're happening concurrently. Then there's an association with arthritis, because arthritis leads to synovitis. Synovitis leads to tendon degeneration, and tendon degeneration leads to tears. Anterior tibial tendon, synovitis, Achilles tendon, paratendinitis. Extensor carpio-ulnaris, synovitis. Then there's association with medications. Anti-malarial medications, HIV medications, and steroids, whether they be corticosteroids or anabolic steroids. So we said yesterday, if the patient denies their anabolic steroids and has a distal biceps tendon tear, they're probably not telling you the truth. And triceps tendon tears are associated with corticosteroids. So here is a triceps tendon tear, corticosteroids. And then associated with internal derangements. People with TFCC tears have more ECU abnormalities. People with rotator cuff tears have more biceps abnormalities. ECU tearing, ECU subluxation. Now the last thing I want to cover before we do an overview, is the concept of dysfunction. A dysfunctional tendon is not working. Now there's three reasons why it may not be working. One is it's torn, so I lose that connection between the proximal bone and the distal bone. I can't go like that. The other is the muscle is atrophied, the tendon is intact, and I have no function because I have no strength to give me the function. And the third thing is my tendon looks normal, but the collagen is so disorganized it can't transmit the vector. And that happens in a surprising number of cases. I think one gentleman asked me about this yesterday in the hallway. You can have a tendon that looks almost normal and does not do its job at all. And that's when it loses that diaphragmal organization. So this patient had a triceps tendon tear. This is a T2-weighted image. We see acute edema. It's an acute tear. Good prognosis. It is repairable. Another triceps tear, but fatty infiltration of the triceps. Irreparable. Never get the function back. So we began with what a tendon does. And a tendon transfers energy from a proximal bone to a distal bone. All muscles have a proximal and distal tendon. We tend to concentrate on the distal tendon because the proximal ones tend to be vestigial. They have a hierarchical organization where they keep on repeating themselves. But they also have a hierarchical organization that they have chemical things that change them, they have morphologic things that change them, and they have microscopic things that change them. And the stretchiness, so you have elastin on a chemical level, you have the crimp on the microscopic level, and you have the undulation at the suboptical level. That's another example of hierarchical. And they have this columnar organization of tenocytes, and each tenocyte is unique, and that prevents it from failing. And they have this anatomy where they get the blood supply from the endotenon, the epitenon, and the peritenon, and those that changes their axis of motion have some deficiencies. They can occur in fibroosseous canals, or they can be freestanding. And they tend to get 4 patterns of histologic degeneration. Hypoxic, with a normal signal tendon of abnormal size, leading cause of pain. Mucoid internal signal, leading cause of spontaneous tendon ruptures. Calcific, self-limited, to some degree protects against tearing, and lipomatous, typically seen in the quadriceps of radiographic curiosity. You get micro tears, micro tears, micro tears, micro tears, micro tears, and then eventually a complete tear. But I want to stress that the complete tear is a consequence of tendinopathy, where you get micro tears that are accentuated by synovitis. Then one sine qua non is incomplete healing. Incomplete healing because there are so few cells, so few tenocytes, that you're predisposed to re-injury because you use your body. And eventually this coalesces to a micro tear. And any patient who has symptoms must have degeneration, and sometimes that degeneration is hard to see on imaging. That specific tendons tend to behave specific ways. Like calcification only occurs in certain tendons. Fibrololipomatosis only occurs in certain tendons. And that you should think of the proximal tendon, the bone, the muscle, and the enthesis as one common biomechanical structure. Now, when we speak about ligaments in an hour or two, I'm going to start out with how ligaments are similar and different from tendons. So this was a good foundation. Thank you for your attention.
Thank you, Professor Schweitzer, for this excellent lecture about an important topic. And now session is open for any question should be directed to Professor Schweitzer.
Yes?
Professor Mark, thank you very much for this very interesting lecture. I would like to ask you about how does statins affect tendons?
Statins? Yeah, predisposes to tendon degeneration for 2 reasons. Good question. I should have listed that as the medication. But also because people are, the question was about statins.
Statins.
Yeah, so statins, low but significant association with tendon disorders. But part of that is because people who have cardiovascular disease take statins. And the cardiovascular disease is also a risk factor for tendon disorders. And it's hard to separate out which of those 2 it is, but probably both.